Good evening. Welcome you all to yet another episode of FCPI. Myself, Mohammed. I am a clinical pharmacist from Astra Mims Hospital, Calicut. I'll be moderating the session for today. So the topic of the day is prospective audit and feedback. And it's my pleasure to welcome our speaker, Dr. Vinda Nambudri. So she is a clinical pharmacist by background, also a postdoctoral research fellow, and has recently completed her PhD in health sciences and research from Amarda. She has been working closely with the AMS program and has various publications to her name. She collaborates on social science research projects with universities from India, UK, and also South Africa. So without ado, we'll start the session. Over to you, Dr. Vinda.
Thank you so much, Mohammed, for that very kind introduction. So I'll just quickly share my screen. Is my screen visible?
Yes, you can go.
Okay. Right. So good evening, everyone. Thank you so much for joining this session. So like Mohammed mentioned, we'll be discussing about a very important intervention of antimicrobial stewardship, which is prospective audit and feedback. So before I begin with the presentation, I would like to state that I have no disclosures to declare. So over the next, say, 30 to 40 minutes, we'll be discussing about antimicrobial stewardship, why it is important, what are the key antimicrobial stewardship strategies, what is prospective audit and feedback, how it is conducted, how it is different from another intervention, which is called formula restriction and pre-authorization. And we'll also be discussing a published example of prospective audit and feedback from India. So to just give you a background or an introduction about antimicrobial resistance, we all know that AMR is a major health and developmental threat across the globe. But even when we say it is a global health threat, it is evidence show that low and middle income countries face a disproportionate burden of AMR, especially because of their challenges related to resource availability. So India is a lower middle income country, and it is also the most populous country in the world. So in our country, evidence show that there is lack of access to clean water and sanitation, which is prominent in many parts of our country. And this is actually a major contributing factor to the high infectious diseases burden in India. In addition to that, evidence also shows that India is the largest consumer of antibiotics in terms of absolute volume. So this high burden of infectious diseases and the unregulated access to antimicrobials in our community actually puts India at an increased risk of antimicrobial resistance compared to the rest of the globe. So there have been a lot of initiatives that have been undertaken in our country to fight against or to combat antimicrobial resistance. So here are just few key initiatives undertaken in India. So in 2012, the first ever meeting of medical societies in India took place to actually discuss about this issue of tackling antimicrobial resistance. So they developed a consensus, which then came to be known as the Chennai Declaration, which essentially proposed a 5-year plan or 5-year strategy on how antimicrobial resistance can be contained in India. In the same year, Indian Council for Medical Research, which is considered as the apex body in our country for formulation, coordination, and promotion of biomedical research, launched the ASPIC program, that is Antibiotic Stewardship, Prevention of Infection and Control, with the aim of bringing together faculty from different disciplines like clinical microbiology, pharmacology, etc., to collaborate in order to initiate antibiotic stewardship initiatives. In the following year, that's in 2013, ICMR launched the Antimicrobial Resistance Surveillance and Research Network to basically establish a network of hospitals in order to monitor the trends in antimicrobial susceptibility profile. In the same year, the National Center for Disease Control launched the National Treatment Guidelines for antimicrobial use. And in the year 2017, India launched its National Action Plan for AMR containment. And in the following year, Kerala became the first state in our country to launch the State Action Plan for AMR containment. Now, in both this, that is the National Action Plan as well as in the Kerala State Action Plan, antimicrobial stewardship has been recommended as a key strategy to optimize antimicrobial use and to fight against antimicrobial resistance. So let's look at what antimicrobial stewardship is. So it actually refers to a set of coordinated strategies to improve the use of antimicrobial medications with the goal of enhancing patient health outcomes, reducing resistance to antibiotics, and decreasing unnecessary cost. So let me just try and break down this definition for you. I'm sure many of you would have learned about rational use of drugs somewhere in your curriculum. So it essentially means that using the right drug for the right patient at the right dose, right frequency for the right duration. So antimicrobial stewardship is essentially a program that tries to implement this very concept of rational drug use. So its aim is to improve the use of antimicrobial medications along with enhancing patient health outcomes, reducing resistance to antibiotics, and decreasing unnecessary cost associated with antimicrobial use. So this is a very important document from Center for Disease Control, which actually elaborates on the 7 core elements of any hospital antibiotic stewardship program. So it is important that these elements are followed whenever an antibiotic stewardship is being implemented. The first element is hospital leadership commitment. So whenever you are implementing a stewardship program, it is important that the hospital leadership is on board. So which includes your medical directors, hospital administration, nursing director, pharmacy director. So these professionals need to be on board with antibiotic stewardship program, because many a times resource limitation is one of the limiting factor that becomes a challenge for antimicrobial stewardship program. So when the hospital leadership is actually on board, it enables human, financial, information technology resource allocation. So this actually supports implementing stewardship to a large extent. The next is accountability. So it is important that stewardship programs have a leader or co-leaders. The most or majority of the publications show that a physician pharmacist co-led program is very successful. So you have a physician, ID physician, and a pharmacist who serve as leaders of antibiotic stewardship program. And they are the ones who are actually responsible for its implementation, its monitoring, its outcomes. So they are the point of contact for this program. Then the third element is you need to have a pharmacy expertise on board, which was previously called as drug expertise. So which is essentially a pharmacist, ideally as a co-leader of the stewardship program to implement efforts to improve the antibiotic use. The fourth element is action, which is essentially your different interventions, antibiotic stewardship interventions like prospective audit and feedback or formula restriction, pre-authorization, implementing antibiotic treatment guidelines, education. There are different antibiotic stewardship interventions. So action refers to implementing these interventions. The next is tracking, basically monitoring the antibiotic prescribing as well as whether the intervention implemented is having an impact on patient care. So it is very important that whenever you do an antibiotic stewardship program, you also measure its outcomes. So you need to monitor whether your intervention is resulting in an improved prescribing behavior or patient care. And you also need to look for what are the different opportunities for improving your intervention as well. The next one is reporting. So when you do a stewardship program, reporting the outcomes of the program to the clinical teams and the different healthcare professionals along with the hospital leadership is very important. So many a times what happens is that antibiotic stewardship programs are implemented. They happen like standalone from the rest of the other departments in the hospital, and many of the times the other departments are unaware about stewardship initiatives. They don't even know that the stewardship program exists in the hospital. Some may know it is there, but they actually don't know what is it that the stewardship program is doing, what are the outcomes they're achieving. So it is very, very important that whatever you do is being communicated regularly to the different healthcare professionals as well as the hospital leadership. The last element is education, which is a very, very important component of any antibiotic stewardship program. So you need to educate different healthcare professionals like clinicians, pharmacists, nurses, and patients about different aspects of antibiotic use, including adverse drug reaction, resistance, optimal prescribing, etc. So education is also considered as an antimicrobial stewardship intervention, but education alone may not be a very successful intervention. So many a times what we do is we combine education with the other stewardship interventions, like when you're doing prospective audit and feedback, education also becomes a part of it. So this education can be done through, giving seminars, didactic lectures, webinars. So there are different ways in which this can be done. But this education component alone may not be a very successful intervention. So whenever a stewardship program is implemented in a healthcare setting, it is recommended that a multidisciplinary team be present. So these are the various professionals who are recommended to be part of AMS teams. And among these different professionals, infectious diseases physicians and clinical pharmacists with infectious diseases training are the two major or the two key role players in any antimicrobial stewardship program. So when you talk about antimicrobial stewardship interventions, there are different interventions, like I mentioned, and among these various interventions, the two key interventions described by guidelines is prospective audit and feedback, and formula restriction and pre-authorization. So for the purpose of today's presentation, we'll be focusing on prospective audit and feedback. You will be having another webinar by another FCPI member who will be discussing about formula restriction and pre-authorization. So what is prospective audit and feedback? So it is basically reviewing the antimicrobial prescription at some point after the medication has been initiated. So what you need to understand is, in prospective audit and feedback, the intervention happens after the antibiotic or antimicrobial is prescribed. That is one major that is a major mechanism that you need to understand, and this mechanism is different in different interventions. Some interventions, stewardship interventions, happen before prescription, and some, like prospective audit and feedback, occurs after the prescription is done and the antibiotic is dispensed. So prospective audit and feedback, it is an external review of antibiotic therapy conducted at some point after the antibiotic has been prescribed. So you need to get this point very clear, that it occurs after initiating antibiotic therapy. Now, this prospective audit and feedback can be implemented in different ways. So depending on the resource availability and the prescribing issues that you have identified, you can implement prospective audit and feedback across the hospital, or based on a specific site of infection or a foci of infection, depending or based on a specific department or location in the hospital, or you can do prospective audit and feedback of a specific antimicrobial class. So how you select how you need to implement audit and feedback is depending on, one, your resources, because prospective audit and feedback requires human resources, time, and dedication. So it is important that you have people on board, professionals on board, to actually do the audit and feedback. So depending on your resources, you can actually tailor your prospective audit and feedback mechanism. So say you don't have a lot of human resource or manpower in your team, so you can start small. So say you only start with doing a prospective audit and feedback in the ICU. And suppose your ICU is quite large and it's difficult for you to, review all the antibiotic prescription there. You can maybe just specify one class of antimicrobial. Say only you're going to review only reserve antibiotics. So in this manner, you can customize or you can tailor your prospective audit and feedback. So I think 2 slides back, I told you that these are the two key interventions. So you have prospective audit and feedback, and formula restriction and pre-authorization. So these are some of the key differences between these two interventions. So like I mentioned, prospective audit and feedback occurs, the intervention happens after the antimicrobial therapy is initiated. In formula restriction, it happens before initiating the therapy. So in formulary restriction and pre-authorization, what basically happens is for a set of antimicrobials, like there is especially like the restricted or reserve antimicrobials prescription, it is mandated that if a prescriber has to prescribe one of these antibiotics, they need to get an approval from the antimicrobial stewardship team. So in some settings, they allow the first dose to be dispensed. So the first dose that the clinician writes for, say, colistin, that can be dispensed, but subsequent doses, if it has to be dispensed, it has to get an approval from the antimicrobial stewardship team. So that is the major difference between prospective audit and feedback and formulary restriction and pre-authorization. So one happens after the prescription is done, and the other one happens before dispensing of antibiotic. So that is the major difference. Second is that in prospective audit and feedback, it is basically considered as a recommending service. So you audit or you review the antimicrobial prescription, and if you find any inappropriateness in therapy, you actually recommend certain changes to the prescription to the prescriber. So whether to accept or reject the intervention or the recommendation, it is up to the clinician. So you're not trying to enforce your recommendation onto the clinician. You are just giving it as a recommendation, and the prescriber can decide whether or not to accept. So basically, it maintains prescriber autonomy. The final decision to change or not to change the prescription is still with the prescriber. But in formulary restriction, that's not the case. There is a loss of prescriber autonomy because the prescriber actually needs to go to the stewardship team to get their approval, and only after their approval, he will be able to give that particular antibiotic to the patient. So in those cases, it becomes quite difficult, especially when, ego and hierarchies and things like that also plays a role in these kind of interventions. So it has its own advantages, but implementing it can become a bit challenging. The third one is, like I mentioned, compliance in prospective audit and feedback is voluntary. So you're just recommending your intervention, and it is up to the clinician to accept or not. But in formulary restriction and pre-authorization, it is direct control over antibiotic use, because only after your approval can the antibiotic be dispensed. So it's more like you're having a better control on antibiotic use. The fourth one is in prospective audit, the success actually depends on the delivery method of feedback. So it is very important that whenever you're giving recommendations to clinicians, you tailor the recommendations to make it more suitable to the recipient. So for example, if you are going to give a recommendation to the surgical departments, rather than talking to them in terms of appropriateness of antimicrobial use, antimicrobial resistance, try to use matrices that actually matter to them. So for example, surgical site infection rates, or hospital or patient mortality rate, or readmission rates. So these are some matrices that they are really concerned about. So you need to slightly modify your recommendation to put it in that sense. So when they see matrices like this, that easily catches their attention, and there is a chance that they get more compliant to your recommendation. So what I'm trying to say is that there is no like one size fits all kind of a concept. You have to really tailor your recommendation, and that can actually improve your compliance as well. In formulary restriction, it is quite real-time resource intensive, because you need to have a member of the stewardship team in hospital for timely approval. So even if the prescription comes at night or during the weekends, you need to have someone from the stewardship team to actually approve the prescription. Otherwise, we might be delaying the antimicrobial therapy for the patient and putting the patient at risk. The last one, the difference is that in prospective audit, since it is the compliance is voluntary, it might take longer time to actually achieve reductions in antibiotic use. And in formulary restriction, unless and until you have a person or a team member always in the hospital to approve the prescription, it may lead to a delay in therapy. Now let's look at what are the advantages and disadvantages of prospective audit and feedback. So like I mentioned, it helps in building collegial relationships. So you are only recommending the interventions. You're not enforcing it on anyone. So that helps to build collaborations with the clinical teams. But what happens then is the compliance becomes voluntary and you may not be able to see the desired effects immediately. The second difference advantage is that the prescriber autonomy is maintained, like we already discussed, but it is quite a labor-intensive process. So you need to have human manpower on board to actually do the audit, review the prescription, go and meet the clinicians and give them the recommendation, go back and review their compliance. So you need to have people on board to actually do this. Another advantage is that it provides educational benefit to clinicians. So every recommendation that you provide from the stewardship team is actually an educational activity to the clinician. So you are giving them an information and you're giving them references, you are giving them evidence for your intervention, and that's actually like an educational initiative. A disadvantage there is that prescriber may be reluctant to change therapy if the patient is doing well. So you are providing your feedback and everything, but since the compliance is completely voluntary, they might feel that, your recommendations are good. I accept your references, everything, but my patient is doing well on this therapy and I don't want it to change. So that is one response that many of us get when we give recommendation to clinicians. Another advantage is that, like I mentioned, prospective audit and feedback can really be customized based on your resources. So if you don't have the sufficient resources, you can actually do it less than daily basis also. So you can do it like once in 2 days or twice or thrice a week. So if you don't have sufficient resources, that should not be a limiting factor for you to not start a stewardship initiative. So you can also just customize it based on the resources. Disadvantage is that it may take longer time to achieve the reductions in targeted antibiotic use. Okay, so what all are required to do a prospective audit and feedback? The first is human resources. Like I mentioned, you need to have a team of different professionals on board to actually collect data, do the review or audit, and then provide feedback. The second is ability to identify appropriate cases. So in many hospitals, this part is actually done by the IT department in the hospital. So where you can actually depend on your IT team to provide a list of patients on certain class of antibiotics, or patients who are in a particular location in the hospital. So you can take their help to actually get the list of patients for whom you need to do the audit and feedback. The third requisite is having support of hospital leadership. This is very, very essential. So whenever you're doing any stewardship intervention, not just prospective audit and feedback, it is important that the hospital leadership is aware about your intervention, and they are aware about the outcomes of your intervention as well. So like I mentioned in one of the previous slides, that kind of support and commitment from the hospital leadership side also enables further resource allocation and recognition for the program as well. And the fourth one is communication with frontline staff. So you need to have a good collaboration and a good relation with the clinicians, the nurses, pharmacists, and the different professionals who are there in the medical and surgical teams, because you are going to give them a recommendation, and the relation that you have with them really plays a role when it comes to acceptance of your recommendation as well. So now just looking at the workflow of prospective audit and feedback. From the title itself, we know that there are two components. You have an audit and you have a feedback. So these are the two major components of any prospective audit and feedback. So when you do this intervention, first step is identifying the cases. So you need to identify so say, for example, you are doing prospective audit and feedback of all patients on reserve antimicrobials in the hospital. So you need to first identify the patients who are on these antibiotics or antimicrobials, then collect data. The stewardship team reviews these cases, and then they provide recommendations to the prescribing clinician. So now you have done the audit, you have found the interventions, you have given your recommendations. So that is one part. Another major part of prospective audit and feedback is also measuring the outcomes. So it is very important that whenever you're doing not just prospective audit and feedback, any stewardship intervention, it is important that you also measure it outcomes to see whether your intervention is actually causing an impact on patient care or on antibiotic or antimicrobial prescribing pattern, and also to look for any opportunities to improve your intervention as well. So these are some of the common matrices that we use to report stewardship outcomes. So you have defined daily dose, days of therapy, which basically looks at the consumption of antimicrobials. Then you have cost of antimicrobials. Then you have patient-related factors like patient mortality, length of hospital stay, hospital readmission rates, etc. So these matrices have been already discussed as part of another session. So I'm not going into too much detail here. But I would just like to reiterate that many of you are doing stewardship programs, but may not be measuring its outcomes correctly. So measuring, and in the next slide, we will talk about reporting of your interventions and outcomes. These two factors are very important, especially in hospitals who have just started the stewardship interventions, because showing your outcome to the hospital leadership and to the clinical teams can help in improving your recognition, improving your buy-in among the clinicians, and also better resource allocation, etc. So the next important concept or part of prospective audit and feedback is reporting your outcomes. So when you're doing a prospective audit and feedback, you will be providing a case-to-case recommendation or intervention. But in addition to that, it is also important that you report on the outcomes on a regular basis. So you can do this like, say, once in a month, you're giving a report to the to different teams, different departments in the hospital, just showing like, how many prescriptions from that department you reviewed, how many you found to be appropriate, or how many you found to be inappropriate, what are the common inappropriate practices that you observed in the prescription. So it could be there are a lot of dosing errors that you identified, so you can give them a data on that. So this can be given as a report to them, or it can be presented, say, like during their departmental meetings, say once a month, once in a quarter, or at least once in 6 months. So basically, it helps you to build a relationship with the clinical teams, and also in the long run, that will help you to improve buy-in and compliance from their side as well. So with that explanation about what prospective audit and feedback is, we will go now into discussing an example of a clinical pharmacist-driven stewardship. So the example that I'll be discussing here is the stewardship program implemented at Amrita Hospital in Kochi. So this is a clinical pharmacist-driven, clinician-led stewardship program. And the major strategy implemented here is prospective audit and feedback. So the process of reviewing antimicrobial prescriptions actually started at Amrita Hospital in 2014, where the clinicians were required to fill out this justification form whenever they prescribed a reserve antibiotic. And this form was actually then sent to the hospital infection control team. It was found that even after 9 months of implementing this initiative, there was no much change observed in the prescribing practices. So then the team did a root cause analysis, and it was found that this process actually lacked the feedback mechanism. So to improve the audit and feedback process, an antimicrobial stewardship team, a multidisciplinary antimicrobial stewardship team was implemented at Amrita in 2016, which was headed by the medical administrator, and it included physicians, intensivists, and clinical microbiologists. So when this program was initiated back in 2016, there was actually a deficiency of clinical pharmacists who were trained in antimicrobial stewardship program in Kerala. So one of the very first initiatives undertaken by the stewardship team was to actually train the Doctor of Pharmacy or PharmD interns who were doing their course within at the School of Pharmacy within the hospital campus. So three PharmD interns were given an opportunity to participate in stewardship program for a period of 2 months on a rotation basis. And during this internship posting, the clinicians in the stewardship team actually gave a very comprehensive induction training for the PharmD interns, which included different aspects. So teaching them what stewardship program is, what is their roles and responsibilities as pharmacists, how do they review a prescription for appropriateness, how do they interpret microbiology cultures. So it was a very comprehensive education that was given to them to take up this role in the stewardship program. So within 6 months of implementing the stewardship program, a clinical pharmacist was full-time employed in the program. And thereafter, even now we have PharmD interns who are posted in our department in the antimicrobial stewardship program. But it is now the clinical pharmacist who is providing this induction training to the PharmD interns. So this is basically the daily workflow of the stewardship program at our hospital. So on a daily basis, the stewardship team or the clinical pharmacist in the stewardship team obtain the list of patients across the hospital on reserve antimicrobials. So the prospective audit and feedback here is only on reserve antimicrobials, but it is happening across the hospital. So irrespective of whether the patient is adult or pediatric or whether the patient is in the ward or in the ICU, every patient on a list of reserve antimicrobials will be audited by the stewardship team here. So they first obtain the list of these patients. So this is through our hospital information system. So it is a computer-generated report on the patients who are on these reserve antimicrobials. Once the list is obtained, the clinical pharmacist and the PharmD interns go to the patient bedside and collect the patient details on a prepared case report form. Then each prescription is first evaluated by the clinical pharmacist or the PharmD intern who is taking the case, and the appropriateness is assessed using a 5R criteria, that is right indication, right drug, right dose, right frequency, and right duration. So we'll discuss about this in the coming slides. So this is first evaluated by the clinical pharmacist and the PharmD intern. After that, each prescription is then discussed with the wider AMS team. So the prescriptions on a daily basis will be discussed with the ID physicians or the microbiologist in the team or the intensivist in the team. And they will, as a team, the stewardship team will come up with recommendations in case they find an inappropriateness in the prescription. And if a recommendation needs to be communicated, it is first documented in the patient file in a specially designed AMS recommendation form. And in addition to filing this in the patient file, it is also communicated to the prescriber via phone or email. Now, once the recommendation is placed, the stewardship team's work does not end there. They actually then go back to see if the recommendations were adhered to. And these patient cases are followed up on a regular basis to look for compliance and to follow up on any microbiology cultures to look for any opportunities for escalation or de-escalation of therapy. So from this workflow, you'll understand that the clinical pharmacists are the key drivers of the program, and their addition actually enabled ownership and sustainability of the program in our hospital. So this is the case report form that the stewardship team uses for collecting patient data. So it includes different aspects of patient data that includes their demographic details, foci of infection-related details, culture details, antimicrobial details, laboratory parameters. So it is a very comprehensive form that enables the clinical pharmacist and PharmD interns to collect a lot of data about the patient. So once they collect the data, like I mentioned, they then look for appropriateness of antimicrobial prescription using this 5R criteria. So these are the 5 R's. So in this, right indication refers to whether the antimicrobial that has been prescribed is the most appropriate in terms of the pathogen that has been isolated, as well as the site of infection. So that is the first thing to be assessed if the antimicrobial prescribed is most appropriate as per the indication. That is as per where the site of infection is and as per the organism isolated. The second is right drug. So right drug refers to ensuring that the antimicrobial prescribed is the narrowest and the most effective option that can be given to that particular patient. So every prescription assessed is on a what do you say, like a case to case basis. So every R that is assessed is very much respect to that particular patient. So with respect to that patient's condition, is the antimicrobial the most appropriate in terms of focus of infection as well as pathogen, whether it is the most narrowest and the most effective option. Then right dose, it's quite self-explanatory. So looking at whether the loading dose and the maintenance dose, is it correct as per the patient's parameters? So like the body weight, the age of the patient, etc. So is it all calculated and it is most appropriate? Then right frequency and right duration is also quite self-explanatory. Sorry, there is a typo here. One is right frequency and the other one is right duration. Okay, so this is a snapshot of how our stewardship team meetings occur. So as I mentioned, it is a multidisciplinary meeting. So you have your clinical pharmacist and the pharmacy interns, and you have your clinicians. Many times the hospital administrator also may be involved in these meetings. So it is a multidisciplinary meeting, and what is the benefit of these kind of meetings is that different perspectives are discussed. So a perspective from an ID physician point of view, perspective of a clinical microbiologist, perspective of a clinical pharmacist. So this kind of approach is very effective because each prescription is viewed or discussed from different aspects. So what you see on your left side is the recommendation form that we use to provide recommendations to the clinical teams or interventions to the clinical teams to improve their prescription. And we also try and congratulate the good practices from a department. So if a department has complete a good appropriateness rate in a particular month, that is also appreciated. So this particular stewardship program has actually led to good outcomes as well. So within 3 years of stewardship implementation here, the appropriateness of reserve antimicrobial prescription improved from 56% to 80%, and compliance to the recommendations also improved from 54 to 70%. In addition to that, the mean monthly consumption of reserve antimicrobials in the hospital also decreased. So the dotted lines that you see that is running through the center of the graph is actually giving the mean monthly consumption of reserve antimicrobials. And as you can see, within 1 year of stewardship implementation, that has reduced. In addition to that, the scope of stewardship program also expanded over the years. So we began stewardship program in our hospital by just doing audit and feedback of 3 reserve antimicrobials. And over time, this has expanded, and the team currently reviews close to 20 reserve antimicrobials being prescribed across the hospital. So this expansion of the stewardship program also led to appointing more and more clinical pharmacists to support the work, which also included a dedicated pediatric stewardship team and an anti-tubercular stewardship program. So in addition to that, the clinical pharmacists in our program were also given opportunities to contribute to research proposals, research projects in collaboration with national and international universities, contributions to manuscript writing, giving opportunities to present at different conferences. So this figure basically shows how the stewardship program has evolved and how the pharmacist role in the program has evolved over the years. So whatever I discussed till now has been the positive side of our stewardship program, but that does not mean that we didn't have any challenges. So in the next 2-3 slides, I'll be discussing some of the key challenges that we had throughout our stewardship implementation and in the following years, and what are some of the steps that we took to overcome those challenges. So the first challenge here is the fact that clinical pharmacists in the team, they had the theoretical knowledge about antimicrobials, but they lacked the clinical expertise to assess the appropriateness of an antimicrobial prescription. So to improve or to overcome that challenge, the clinicians in the team provided hands-on training. So this included the induction training that was provided, which I mentioned in one of the previous slides. And in addition to that, even case-to-case basis training was provided to the physicians, to the clinical pharmacist. So when the cases are discussed during the stewardship meetings, that is also a time when the physicians try to teach clinical pharmacists about the different aspects of antimicrobial prescription. And these meetings are also a platform for education. Another step that was taken is giving opportunities to clinical pharmacists to attend conferences and to attend online courses on antimicrobial stewardship to understand how stewardship is implemented, what are things to be noted. So those aspects were tried to be taught to them through these different mechanisms. And in addition to that, clinical pharmacists were also encouraged to do weekly journal clubs where they discussed recent evidences of antimicrobial stewardship practices from different countries during these journal clubs. So these journal clubs also provided a platform for shared learning opportunities to the clinical pharmacist. The next challenge was that initially when the stewardship program was implemented in our hospital, many of the clinicians saw it as a closed room approach, where they felt that the clinical pharmacists were just sitting inside a room, looking at the computer and assessing prescriptions just based on whatever information they could get from the hospital information system. So to clarify that, the clinicians in the team and the hospital administrators try to talk to the clinical teams to inform them that the model that we have adopted is a clinician-led clinical pharmacist stewardship model. And it is a combined recommendation from a team of experts that was actually being communicated by the clinical pharmacist to the clinician. And they also informed the process and how the stewardship is done to convince them that it is not it is also having a bedside review of prescriptions. The next initiative that we took to improve that compliance was also to provide evidence base for the recommendations that we provide. So rather than just giving them the recommendation form and asking them to change the antibiotic or to change the dose of the antibiotic, we also provided a reference or an evidence base for that recommendation. Then what we did is we tried to meet with the frequently non-compliant departments. So if we found that a department is not at all complying to a recommendation, we tried to meet with them in person. So we used to have combined meetings with the department and the whole stewardship team to basically understand what are their challenges in accepting our recommendations, or there might be some things that we are missing because we are depending on the patient file for maximum data collection. So there might be some parameters that we are missing. So these meetings really helped us to understand their decision-making process as well. Then we also started having bedside review of complex cases by the clinicians in our team. And initially what we used to do is whenever we have a recommendation, we used to communicate to the junior members of the team. So over time, what we found is that these recommendations that are communicated to the junior members are not actually reaching the senior members of the team. So having recognized that as a challenge for our compliance rate, we try to then ensure that these recommendations are communicated directly to the senior members of the team whenever possible. The third challenge, which I'll be discussing here, is that the stewardship program at our hospital has not been able to expand beyond the reserve antimicrobial audit and feedback, especially because of manpower limitation. So in order to, I wouldn't say overcome it, but just to understand the prescription of other antimicrobials in our hospital, the team started doing point prevalence surveys, studies at different time intervals, just to understand how the prescription of other antibiotics is in the hospital. So why I have tried to discuss these challenges is that many a times when we as stewards, we face these challenges, we feel that the stewardship program is not successful and we try and discontinue the program. But challenges are bound to happen. Whichever intervention you take, you will have some or the other challenges. But it is important that you as a team also try and bring out some solutions to overcome those challenges. So with that, I would like to conclude my presentation. And I can take any questions if there are any. Thank you.
Yeah. So thank you, Dr. Vinder, for such an insightful presentation. So without any delays, we'll start the Q&A sessions.
Sure.
Since we don't have anything in the chat box, I'll put forward a few questions to you.
Sure.
So the first thing I would like to ask you is like, what would you say is the most important next step for some organization or practitioners looking forward to, looking forward to implement this prospective audit and feedback in their settings
So
effectively?
I would say, like, if any organization or any hospital wants to implement a stewardship or a prospective audit and feedback, first they need to understand what is the prescribing issues in their setting. So if is it the irrational prescription of reserve antimicrobials, or is it inappropriate management of certain focus of infection? So if you actually read published evidences, there are a lot of studies that talk about, say, asymptomatic bacteriuria being inappropriately treated, and or say ventilator associated pneumonia. Or you can uh, customize your intervention based on what is the issue in your hospital. So first is understanding that issue. So you can do it, like, say, you can do a point prevalence survey, you can audit the prescriptions and see what is the major issue, and you can decide on your intervention based on that. So that is the first thing. That is to understand the problem and then to customize the intervention based on that. Second is identifying the resources in hand. So like I mentioned, prospective audit and feedback is a very resource intensive process. You need to have a team to audit the prescription, to provide feedback, to look for compliance, to then monitor the patients until discharge. So it's a very tedious, very long-term commitment kind of a process. So you need to have a team on board to do that. So if you don't have that team, you can start small and then go on expanding your intervention. So you maybe start with one department or one location in your hospital, and once you have established the methodology, workflow, and you are familiar with the workflow, and then you can gradually expand it to the different departments in your hospital. And also, like I mentioned, reporting is a very important thing. So many stewardship programs are happening, but the other departments in the hospital are not aware about this. So which is why the compliance is a major issue. Like if you took a look at any stewardship model, one of the major challenge is the compliance to their recommendations.
Yeah.
So that is because there is not much relationship between the stewardship team and the clinical teams in the hospital. So building that relationship is very important. So having a hospital leadership support definitely adds to that. So when you have your hospital leadership on board, that gives you a better recognition among the other department also. So I would say these are some of the things that hospital teams need to consider when they are implementing stewardship.
Yes, thank you. I totally agree with you. And one more question to wind up. So, what's the one key takeaway that you would like to everyone to remember from today's session?
So major takeaway would be that just because you don't have the resources or you don't have the capabilities, that should not be a limiting factor to start stewardship. So
Yeah.
prospective audit and feedback can be started small and then escalated. So just sitting back saying that, you don't have the resources is not the answer, because stewardship is very much important, especially in a country like India. Like I mentioned in my initial slide, we have a lot of inappropriate antibiotic use, both in the community side and in the hospital side. So we need interventions like stewardship to do that. The second thing that I would like to convey is, I know a lot of you who are listening also are doing a lot of stewardship interventions in your hospital, but these are not published. These are not presented at conferences. So many people don't know about it. So even now, if you
Okay.
look at publications on stewardship from India, it's not too many. But when we go and meet people, or when you look at their LinkedIn profiles, you will see that there are lots of pharmacists who are doing stewardship. But it is very important that whatever you do, you might feel that it is small, it is not that impactful, but when you go and present it somewhere, it can just be as a poster. If you just present it as a poster or you just publish it, someone elsewhere might find it useful. So there might be some other pharmacist who is there in some other part of India who wants to implement stewardship interventions, but he or she is clueless. So
Yeah.
whatever you publish or whatever you convey can be a lesson for them, and that might help them to do it. So you should not feel that only if stewardship is super impactful and you're getting all these amazing results, you can publish it. Publishing your challenges is very important.
Yes.
Like the challenges that I mentioned, I presented here, it has been published, so it's there in a publication. So when you do these things, one, it improves your visibility and your recognition, and two, it will improve the stewardship importance of stewardship in our country, and three, it will improve the recognition of our profession. So clinical pharmacy is still evolving in our country, and we keep saying that we don't have the sufficient opportunities to work in India. So actually presenting or publishing what the amazing interventions that all of you do is very important to improve the opportunities for us in our country as well. So these would be my key takeaways.
Thank you for sharing your expertise with us today. So this was an incredibly valuable session, and we appreciate the insights you have been provided on this particular topic. So thank you everyone who joined us, and we hope you have as 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 I have. I have benefited from this session. I feel you also have benefited from this session. And with that, we'll wind up today. Have a great day.
Thank you, everyone. Have a good evening.